Welcome to Medscape. I'm Dr. Andrew Wilner, reporting from the American Epilepsy Society meeting. Today, I have the pleasure of speaking with Dr. Chethan Rao, a child and adolescent neurology resident from the Mayo Clinic in Jacksonville, Florida. Dr. Rao has a particular interest in pediatric epilepsy. Welcome, Dr. Rao.
Thank you, Dr. Wilner. It's a pleasure to be here, and thanks for taking the time to highlight our work.
Yes, well, you had a very interesting paper at the meeting that I wanted to talk about infantile spasms and smartphone video. So before we dive into the paper, tell us a little bit, what are infantile spasms and why is it important to diagnose them early?
Sure, yeah. So infantile spasms, also known as epileptic spasms, are 1 to 2 second seizures, and they typically consist of sudden stiffening of the body with brief bending forward or backward of the arms, legs, and head. They usually happen around ages 3 to 8 months, and they typically occur in clusters, most often after awakening from sleep. The incidence is about 1 in 2 to 3,000 children, and many kids with spasms go on to develop seizures that are very difficult to treat, like Lennox-Gastaut epilepsy, and many go on to have developmental delays as well.
Now, are these subtle? In other words, could a parent have a child like that and not really recognize that this is something abnormal, or are they so dramatic that it's like, whoa, we're going to the emergency room?
Yeah, so one of the problems that we encounter often is in this age group of infants, they have benign sleep myoclonus, they have Sandifer syndromes related to reflux. Those can be very difficult mimics for spasms. So they're not the most clear cut, but they look usually different enough from normal baby movements that they get parents to seek medical attention.
Now, you mentioned that the infantile spasms really are a type of epilepsy and symptomatic usually of some underlying neurologic condition. But why is it so important to diagnose them early?
Yeah, great question. So there have been a lot of studies that looked at developmental outcomes based on when spasms were diagnosed and treated. And all of them have really shown, replicated time over time, that the earlier you get to treatment to spasms, the better the outcomes are for seizure control, the better the outcomes are for development. So for this reason, infantile spasms is considered a neurological urgency in our world. And like I said, accurate diagnosis is often complicated by these potential mimics. So prompt EEG is one of the most important things for a confirmation of diagnosis.
Right, but to get that EEG, it has to get all the way to the neurologist, right? That's not something they're going to do in the ER. So, I saw a statistic. There are millions, if not, I think billions of smartphones out there. So where does the smartphone come in?
Yeah, absolutely. So one of the things that we have on our side these days is almost everyone has a smartphone at their disposal. One of the recent polls last year showed more than 95% of adults in childbearing age have smartphones with video access. So, as some other studies have shown in the adult world, we all really have a, epilepsy monitoring unit minus the EEG in our own pockets. So it's definitely a useful tool as that first screening video that's used in adjunct to history and physical. There have been a lot of studies on the adult epilepsy side showing predictive value of smartphone video for differentiating things like epileptic seizures and non-epileptic spells. And what we wanted to do is to use smartphone video for really being able to pin the diagnosis early of infantile spasms and get it treated as quickly as possible.
Yeah, I'm a fan. Every now and then I do have a patient who brings in a video of some spell. I'm an adult neurologist and the patient had a spell and you ask them, of course, they don't remember. And you ask the witness, who usually is not a trained observer, And there's been one or two occasions where I was, well, I don't know if that was really a seizure. And then they show me the video and it's like, whoa, that is definitely, a convulsion. So a picture definitely can be worth 1,000 words. Now, you studied this kind of systematically for your poster. Tell me about what you did.
Right, right. So since the poster, we've actually expanded the study some. So I'll give you the updated version. We looked at 101 infants retrospectively at two large children's healthcare centers. So our Nemours Children's and associated with Mayo Clinic in Jacksonville, Florida, and then Texas Children's Hospital in Houston, Texas. And we narrowed it down to 80 patients that we included. 43 had smartphone video capture when they first presented, and 37 had no video when they first presented. And what we found was a 17-day difference by median in the time to diagnosis and treatment. So in other words, the video group was diagnosed and treated 17 days by median compared with a no video group. And while 17 days may not sound like a big number, in this context, it can make a huge difference. And that's been shown by one of these key studies in our field called the UK infantile spasm study. And that 2-week difference made about a 10-point difference on the developmental scale that they use. So pretty significant.
Now, let me think about this for a minute. Was that because the parents brought the child in with their video and the doctor said, hey, that's infantile spasms. Here's your shot of ACTH or whatever they're using these days? Or was it just because the parents who were sort of attentive enough to use video, just brought their kids in sooner? Or was it this was the time from when they brought the child in to treatment? Is that what the time you looked at? So it wasn't just that these were more attentive parents and more likely to use the video. You're looking at the time from presentation with or without video until treatment. Is that right?
We looked at the time from the start of the spasms as reported by the parents to the time of diagnosis, and then the start of spasms to the time of treatment. And what you asked was a fantastic question. We wanted to know, who are these parents that are having taking video versus the ones that are not. So we looked at the race, ethnicity data and socioeconomic status data, and there were no significant differences between the video and non-video group. So, that would not explain the difference in our results here.
Okay, so do you have plans to actually follow these 40-ish children, 5 years from now and see, who's riding a bicycle and who's still, stuck in the stroller? Is there gonna be a difference?
Yeah, so since time to diagnosis and time to treatment were our primary outcomes, long-term follow-up may not really help us much in this study, but we did have a couple of other ideas on future studies. So one that we wanted to look at was for kids that have risk factors of developing spasms. So things like trisomy 21, tuberous sclerosis, congenital cortical malformations. Those kids are much higher risk for developing spasms around this 3 to 8 months of life. So in giving targeted counseling to those families about how they can use smartphone video to really minimize the time to diagnosis and treatment, we think we may be able to learn more and maybe do that prospectively. The other thing that's an interesting idea is using artificial intelligence technology for spasms detection in some of these smartphone videos. So they're already using it for different seizure types, and it could be an efficient first pass when we get a whole bunch of smartphone videos. How do we know which ones we need to pursue further steps to see if we need to get long-term EEG monitoring or not?
Right. Well, as an epileptologist, I was going to say we have smartphone EKG, right? So all we need now is smartphone EEG, right. And then you'll have all the information you need on day one.
Yeah.
It may be a ways away.
Mhm.
But as a bottom line, would it be fair to say that parents should not hesitate to take a video of any suspiciously abnormal behavior and bring it to their family doctor or pediatric neurologist?
Yeah, I was happy to see the Tuberous Sclerosis Alliance put out a promotional video that had some steps when parents see things that are suspicious for spasms, and they do recommend using smartphone video and promptly showing it to their doctors. I think the difference that we hope to provide in this study is that we can now quantify the effect of having that smartphone video when they first present. So my takeaway from this study that I would like to show is encouraging the use of smartphone video as an adjunct tool, and for providers to ask for the videos, but also for these pediatric centers to develop an infrastructure. So either a secure monitored email address like we have at our center, or a patient portal where parents can submit video concerning for spasms.
Right. Save the trip to the doctor. Get that video out there first.
Right. Especially
Sure.
in the pandemic world, right?
Yes. Now, I understand that you are a neurology resident. So, to wrap up, what's the next step for you?
Yep. So I'm finishing up my child neurology residency this year, and I'm moving out to Stanford for pediatric epilepsy fellowship. And we're preparing this project we're talking about for submission soon. And we're working on another project, which is a systematic review of genetic testing and the pre-surgical workup for pediatric drug-resistant focal epilepsy.
Excellent. That's all. That's pretty exciting. Well, good luck to you.
Thank you.
And I want to thank you very much for telling us about your research.
It was a pleasure speaking with you, and I look forward to the next time.
Well, I'm Dr. Andrew Wilner reporting for Medscape. Thanks for watching.